I guess pueden hacer sus preguntas en inglés o en español. Las hacen en español, que los puedo traducir y bueno, Jeff va a responder en inglés, ¿no? So, people can ask in English or Spanish, they can translate. So, ¿quiere alguien hacer alguna pregunta? O comentario, de cualquier tipo, ¿no?
Might not be a very good one, but you mentioned that like you might be able to look into using azithromycin to treat syphilis here if you could detect that it was resistant. What would be the advantage of that besides, is there any advantage besides just being oral?
Yeah, so you want to translate the question?
Because people
Understand the question?
Yeah.
Okay, so I'll repeat the question. So the question was, why do we want to learn more about azithromycin and resistance, particularly here? What are the advantages of using oral therapy with azithromycin over injectable penicillin? Well, one immediate advantage, and we learned this yesterday, is that the Barton Clinic is short on syringes. So patients on occasion have to pay for their own syringes, and that is a deterrent to treatment. The second thing is it impedes our ability to do partner treatment. That if we could do partner treatment with azithromycin, we may be able to have a better handle on the epidemic. Third, if we think about really syphilis control, an oral drug like azithromycin could be used as PrEP, prophylactically. Also, potentially could be used. There's still a reluctance by many providers if someone's been exposed to syphilis to treat them prophylactically. Even though that's the standard and what's recommended, most providers will still get a syphilis test and then only treat them if their syphilis test is positive. That's actually the wrong practice because you're supposed to treat people after their exposure to prevent them from getting syphilis and not wait till they seroconvert. And azithromycin, because it's easier to take, easier to give, less associated with fearful side effects of hypersensitivity, which is not zero but is incredibly rare, maybe more amenable to be used as a preventative. So one of the challenges, and what part of our study is going to explore this, is it's hard to get the organism from patients with syphilis. So we can diagnose it based on serological tests or based on clinical findings, but it's hard to get the DNA from the organism. So to do targeted treatment based on a susceptibility profile is not impossible, but it's difficult. As opposed to other infectious diseases, staph, strep, gonorrhea, we can potentially more readily look at susceptibility. But if it's like Tanzania, where there's no azithromycin resistance, it could be a useful tool.
Sorry. I would like to know if in the study you're doing with rapid test self-administered, do you use any kind of counseling, pre-test counseling, or just directly the test for them?
Okay, so and it's about the self-HIV test?
Yes.
Right, because we also do self-collection for the other STDs. But for the HIV tests, it's really targeted to repeat testers, so not necessarily first-time testers, but there's nothing that prevents first-time testers from accessing it as well. And there is no formal counseling. So there is education available through informational pamphlets, through information on a website, through a 1-800 telephone number, but it's not required that anyone undergoes any specific pre-test counseling. And as you may know, the U.S. has moved away from requiring counseling, but also people use counseling sometimes differently. Some people consider counseling education. You should understand how the test works, what the risks and benefits of the test are. Other people consider counseling as risk reduction counseling. We want to move you to a spectrum of being safer. I think it is important that people understand how the test works, the risks and benefits of the test, so education, but we moved away from requiring counseling.
Sí, puedo añadir sobre eso que hay un reconocimiento de que en muchos lugares por el estigma que había antes en torno al diagnóstico y el efecto psicológico que un diagnóstico positivo podía generar, se estableció la necesidad de consejería muy intensiva, pre y post, ¿no? Sin embargo, con el tiempo se reconoce que el diagnóstico de positividad, por un lado, ha perdido el impacto negativo y, digamos, destructivo que podía tener psicológicamente la persona, y por otro lado, tiene que asociarse cada vez más a una vinculación al servicio de salud, a la atención y al tratamiento temprano, ¿no? Entonces, eso hace que un énfasis excesivo en demasiado sigilo o, digamos, demasiada ceremonia y consejería repetida puede ser una barrera, ¿no? Eso no significa, obviamente, que se trabaje con una prueba no voluntaria. La prueba tiene que seguir siendo voluntaria y tiene que seguir habiendo información, ¿no? Pero hay una tendencia además a pasar de un modelo de consejería que es lo que llaman user initiated o client initiated, o sea, a demanda de la persona, hacia un modelo que es provider initiated, que es ofrecido por el servicio, ¿no? Donde la persona puede decir que no, ¿no? Pero ya se le ofreció, ¿no? No fue por él, pero se le ofreció y si quiso lo tomó, ¿no? En vez de esperar a que la gente vaya a buscar, ¿no? Entonces, creo que la idea es esta cascada, tratar en lo posible de identificar a las personas pronto, tempranamente, porque obviamente no solo es un tema de beneficio individual, sino también de beneficio preventivo para la colectividad, ¿no? Entonces, ese es un poco el enfoque. I wanted to ask a question about how do you feel, how easily do you feel there is a transition between traditional prevention based on behavioral change and the incorporation of biomedical strategies, particularly in the US. So do you think it's happening easily? What are the obstacles for that?
Yeah, so, for 30 years, primary prevention focus, I think, has been on risk reduction in terms of behavior change for individuals. And I think that's been important for some populations, but hasn't been adequate, to control the epidemic. I mean, you still have populations of heterosexual men in many urban areas where 2% a year are getting infected, which means in 20, 30 years of their sexual lives, half will be HIV infected. And recognize that behavior change on an individual basis is complicated, and there's a lot of different motivations for people to engage in risk behavior. There's demotivations for them not to engage in safer sex, and the funders who are looking at research are recognizing that we need kind of larger, more structural, more system level interventions that don't require necessarily an individual to make behavior changes that they're not ready to make or they're not supported to make. So as the funding has changed and evolved, we see less focus on these types of risk reduction, specifically risk reduction interventions, and more on this kind of case identification and treatment. And as someone who's personally supported case identification and treatment and seen it be successful in syphilis elimination in many populations, for other disease control activities, I think there's value there. And it doesn't say you don't need to do education and people don't need to understand how HIV is transmitted, and education in terms of what's safer and less safe. But the idea that people can come into groups and multiple group sessions, or that repeated individual counseling sessions can have a epidemic impact, I think people are generally less enthusiastic about that. So I mean, there was this, one of the large, very expensive studies was called Project Explore, and they had high-risk men assigned to a 10-session intense counseling effort with very strict, high-quality counseling intervention, and it was targeted to that individual's needs: substance use, mental health, child sexual abuse, and they had professional counselors, and they compared that to a kind of education condition. And these were highly motivated men who engaged in the study, so highly select group, and they found no benefit. And I think that really took the wind out of the sails of people's expectations for what you can get out of the best kind of individual level prevention. And for group level prevention, it's been, you know, for small groups and multiple group sessions, I think it's been difficult to scale up. So while they've been shown in some of the best settings and, you know, among trialists to have some impact on behavior change, implementation has been difficult, and there's been this kind of pushback by the more medical-minded folks. You know, well, we need to get people tested and get them on treatment.